Hello everyone, welcome back to another live surgery session. My name is Sujin Yang from Korea and I'm honored to participate as moderator of today's case. First of all, I deeply thank Dentium Corporation that has made today's seminar possible. I believe that with today's online seminar, as well as the many webinars Dentium has yet to offer, we will be able to actively share information and experience amidst this ongoing COVID-19 crisis. Today's operator is Dr. Kang-Hee Lee, who has much experience in both the surgical and prosthetic fields of implant dentistry. I hope that through today's seminar, I will be able to convey intriguing and helpful information to the surgeons and dentists watching this video, and I will try my best to convey as much information possible from the operating room. I also wish that through this seminar, you will be able to have a better understanding of the Dentium implant systems, materials, and additional tools that will be used in today's case. We also have a comment window below this video, and it will be open while running live. So please feel free to express your thoughts or questions anytime during this seminar. Okay. So first, today we'll be watching a case of implant placement and immediate loading on the upper posterior regions using a digital guide. Therefore, today's case will be covering both implant surgery and immediate prosthesis using Superline implants from Dentium, a digital guide, and pre-made temporary bridges. First, I will briefly introduce today's case before we move on to the actual surgery. Today's patient is a 70-year-old male, and his chief complaint was that he wanted to have molars in the upper jaw. The patient was using an old removable partial denture on the maxilla, but recently did not wear it due to discomfort. The patient's underlying diseases were hypertension and hyperlipidemia, and was taking aspirin every day along with other medications. Therefore, straightforwardly, today's surgical plan is to place 5 implants in the tooth number 17, 16, 24, 26, 27 areas using a digital guide and Superline bone level implant fixtures, and to perform immediate implant prosthesis on the posterior regions using a pre-made temporary abutment and bridges. The sites of each implant area will be examined in the following slides. Now this is the panoramic radiograph taken recently before today's surgery. The X-ray shows a dentulous ridge in the upper right and lower left molar areas, and we can guess that the upper right molar areas show insufficient bone height. So, sinus augmentation will be necessary for implant placement. Tooth number 23 shows apical radiolucency and secondary dental caries under the post and core of the coronal portion. Tooth number 14 has lost bone support due to advanced periodontitis. The lower dentition shows mild to moderate alveolar bone loss, but no significant mobility was present. Now, these are the intraoral photos of the patient. Mild overjet and overbite of 2 to 3 millimeters can be seen from the frontal and lateral views. Tooth number 15 and 45 are acting as the vertical stop of the patient. Tooth number 14 shows bone loss along the full length of the root. Tooth number 47 shows mild eruption or extrusion up to 2 millimeters, so this will have to be considered when the restoration of the final prosthesis on the upper implant is done. The mandible seems to be very slightly shifted to the right side because the sole area of the posterior support is on the right premolar area, that is tooth number 15. But the patient did not show any discomfort of the present jaw position and did not present any signs of TMD or joint problems. Thus, this position was used as a base reference for designing the temporary prosthesis. The crown height space is 8 to 10 millimeters on the right side and about 8 millimeters on the left side. Therefore, the crown to root ratio of the implants will be disadvantageous on the right side, and the design to minimize lateral force on the implants will be critical. Now, in this case, no bite raising or mandibular shifting would be necessary, but during temporalization, Dr. Lee will have to make adjustments to confirm that the final jaw position and vertical height is comfortable before the final implant prosthesis. Now, in the occlusal views, no noted attrition is present and no severe amount of arch width loss or bone resorption is present in the occlusal views. Therefore, establishing a cross-bite or edge-to-edge birelation for the implant crowns and the lower molars is unnecessary or seems unnecessary in this case, but it is always important to compare the buccolingual relation of the opposing tooth as well as looking into the crown height when planning an implant surgery. When planning for an implant surgery, we tend to focus only on the remaining bone volume, but the importance of regarding the crown position and planning a surgery in a top-down manner can never be overemphasized. Also, as practitioners, we all know that losing mutual protection from the anterior teeth can be devastating to the patient. No guidance from anterior coupling always has a bad influence in worsening the posterior interference, leading to poor prognosis of the final prosthesis. This is especially can be more critical in implant prosthesis because implants are very vulnerable to lateral forces. Even with improved implant surfaces and fixture designs, it is still important to have such prosthetic concepts in mind during the whole treatment procedure for more promising results. Therefore, further crown treatment on tooth number 14 and 23, or in worse possibilities, extracting these teeth and putting an implant in that area as well, and splinting the implant crown with the remaining implants can be regarded in future. Now we will go over each site upon the CT scan. The tomographic images of the patient shows detailed bone volume around the implants. Tooth number 17 area shows sufficient bone width, but not enough bone height. Tooth number 16 area has more bone compared to tooth number 17, but still a small amount of sinus floor elevation may be necessary. We'll have to check during the surgical procedure. Now, tooth number 24, and 26, and 27 areas have sufficient bone with moderate height of approximately 8 millimeters, so we can assume no additional bone graft would be necessary. However, in cases where the implants are positioned deeper than the alveolar bone crest, a small amount of elevation of the sinus floor might be necessary, and since in cases where the implants are positioned too deeply, some interference can be present between the fixture and the healing abutment, so some amount of bone preparation after the implant fixture placement may be necessary as well. Now, the following slides represent the cross-sectional view of each implant position following the analysis on the CBCT using Dentium software. This is a software made by Dentium. We will be using superline implants from Dentium, and the size of the implant is shown on the upper right side of the slide. For example, Dr. Lee plans to put an implant having 5.0 diameter and 8 millimeter length in the tooth number 17 area. Since this area lacks sufficient bone height, that is vertical bone height, sinus floor lift or augmentation will be performed. The bone height is approximately 4 millimeters to 6 millimeters, so sinus lift using the crestal approach will be performed with additional bone graft into the elevated space. As for the implant in the tooth number 16 area, the platform position was set in accordance of the bone crest on the palatal side. As a result, some amount of bone contouring would be necessary on the buccal side. Matching the platform height of the implants on tooth number 17 and 16 area will be advantageous for further prosthetic work and implant maintenance, but Positioning both implants deeply so they are positioned into the patient's bony housing results in longer crown height space, that is, worsening the crown to root ratio. The pros and cons can be considered, and to which position should the implant be placed is a factor that the dentist can decide. Now, on the left side, tooth number 24 and 26, 27 areas have sufficient bone height and width. The diameter and length of the implants were set to 4.5 millimeter width, 10 millimeter length for tooth number 24, and 5 with 10 millimeter length for the molar areas. I think Dr. Lee might do an additional bone graft in these areas using the crestal approach if necessary, since the inferior border of the sinus can always be a little different from the CBCT and in the actual surgical situation. Also, through the CT images, we can assume that the bone density, we can assume from the CBCT that the bone density will be about D3 to D4 in most sites. So careful drilling to ensure initial stability will be important. In cases where the bone density is very low, initial stability is hard to get, and in devastating situations, the surgeon might not be able to install the implants and has to do a bone graft and try later on, which is a result nobody really wants. Now, this is the overview of the virtual setup. The implant positions as well as the anatomic references can be confirmed through the planning procedure. The white crowns in the slide you are seeing now show the outlines of the ideal crown shape and position, and this information will be used to prepare the prefabricated provisionals and the temporary abutments. It looks like the provisionals show normal overjet in the right molars, but we will see if any adjustments will be made when we go into the operation room. Now, what is good about this digital guide software from Dentium is that the surgeon can easily make additional adjustments considering the crown shape, angulation, by three-dimensionally rotating the patient's scan file within the software. So this image you're seeing now, it can actually be rotated three-dimensionally in the software. Also, the angulation of the fixtures and hole positions following each implant angulation can also be easily confirmed. The guide template, temporary abutments, and temporary crowns are ready-made through this procedure and delivered to each clinic. Now, before we move on to the operation, we will go over a similar case so that we have a clear view of what today's case will look like. Now, this is a full mouth rehabilitation case done by Dr. Kang-Hee Lee as well. And the full mouth rehabilitation was done using a digital guide. As you can see, there is a remaining supernumerary tooth on the central incisor area of the maxilla. So this tooth was extracted for hand, and bone graft was done in the extraction site. Lateral sinus augmentation was done on both sides using materials from Dentium. That was probably a osteone and a membrane 1 or 2. And after that, after some amount of healing, full mouth implant placement was done. Implants were placed in the upper right and left edentulous areas with extensive bone graft and soft tissue graft in the upper right canine area. Immediate provisionalization was performed on the same day. The temporary bridges were delivered with minimal occlusal adjustments. Now, I think we've dealt enough, so we'll move right to the live surgery session. Okay, Dr. Lee has already started the surgery. Oh, and as I've mentioned before, we have a comment window below the video, so please feel free to express your thoughts or questions during this seminar. Okay, usually the digital guide system accommodates up to 5.0 diameter because as long as there is enough bone, a 5.0 diameter implant is chosen as a gold standard in most posterior cases. And but it's always safe. When planning a digital case, it's always safe that your guide matches the implant system that you're using and accommodates up to the diameter that you're planning to use. The digital guide was made with a non-metal sleeve in this case as well. Dr. Lee, I think he prefers a non-sleeve design because usually when using metal sleeves, because the sleeve itself is so rigid, the implant drills tend to get stuck in an unfavorable position. Okay, so Dr. Lee is punching out the soft tissue in a flapless surgery method. And as you've seen now, Dr. Lee is pressing onto the stent firmly with his left hand. Without doing this, the stent can move in an anterior-posterior way. It can sort of jiggle around in the mouth. So it's very important to constantly check the stent is securely positioned within the patient's mouth. Usually those windows that are positioned on the right canine area you're seeing now act as very good reference points, so please make sure your stent is always secured in the same position. Otherwise, we'll have implants positioned in the wrong place. When looking at the drill hole positions or the prepped areas right now, you can see that it's very close to the vestibule, and I don't think there would be enough keratinized tissue on the buccal side after the implant is placed. I think maybe the implants were a bit, the preparated place is a bit positioned buccally compared to the originally planned guide position. So Dr. Lee might have to change the position manually. So in most cases, the holes of the stent and the surrounding gingival status should always be double checked before actually going into the surgery. If the holes are deviated to one side or if the tissue around the implants are unfavorable, changes can be made in reference to the prepared guide. Dr. Lee has probably under-drilled drilled the number 17 area not in full depth to do the bone graft and the osteotome, using the osteotome and doing the sinus lift firsthand. Okay, Dr. Lee, after preparing the sites, he is trying to place the implant in the number 16 area. I believe he has planned to use implants with diameter 5.0 and a length of 8 millimeters. He is withdrawing because the implant cannot be placed in the area he wanted it to be in. I think he might just start reflecting the flap because there isn't a sufficient amount of keratinized gingiva on the buccal, and I think the initial stability on the number 17 area would be a little tricky. And the mouth opening of the patient, I don't think it's wide enough compared to other helpful patients. Even if we think that an implant case would be very easy before we actually start the surgery, there can be a lot of hindrances because there are patient factors, like for instance, the patient can have a problem with breathing through his nose, or have limited amount of mouth opening, or in some cases have a problem with securing his tongue. Okay, so Dr. Lee has put bone graft material into the number 17 area and is performing the sinus floor elevation as well as bone compaction using the osteotome. I think he will try to place the implant on number 17 once more. The torque and RPM for implant placement or drilling, it can be a little different from surgeon to surgeon on his or her convenience, but usually there is a recommended RPM and torque for implant placement. So I suggest you to follow these instructions first, then make modifications according to your preferences. Okay, so Dr. Lee has placed both implants into the areas and is now securing them with a hand wrench. By using a hand wrench, you can see that the initial stability amounts up to a certain number, Newton, but the surgeon can also feel the initial stability by the force or the resistance that he or she feels with the hand wrench. Okay, so when using a surgical guide, usually a flapless surgery method is used, as in this case, but it's always possible to actually reflect the flaps because by doing a open surgery, that is, there are many pros. The best thing is that you get a lot of visual access to where you're preparating. And Dr. Lee has positioned the implants and is now reflecting the flap. He could have done this before actual implant drilling, but I think the reason that he is reflecting the flap now is that the guide was okay, so he placed the implants first, but there isn't enough amount of keratinized tissue on the buccal side, so I think he will reflect this flap and position it like in a way that a apically positioned flap surgery is done, so to make sure that the patient has enough keratinized gingiva when the surgical site is healed. The patient has a lot of bleeding. Now, even if this implant site is a site that was without any granulation tissue or inflammation because it was an edentulous site, an extensive amount of bleeding can still be present, considering the patient's medical history or the medications that he or she is taking. This patient, for instance, if he was taking aspirin before surgery, then this could have led to this abundant amount of bleeding. In the surgeon's perspective, bleeding is what we really don't want because it's a hindrance, because it, first of all, blocks the surgeon's view. It makes everything go slower, and it's very hard to have a clean bone graft done when we have extensive amount of bleeding because it just flushes everything away. Okay, so after flap reflection, you can, the good thing is that even if you've placed your implants beforehand using a digital guide, you can always confirm the actual position after reflecting the flap. And it's sometimes a thing that is recommended, or say a thing a surgeon should do once in a while, I think, or once in a lifetime, because it's actually very important to confirm that the implant position according to the digital guide actually goes into the ideal bony housing that we actually want it to be positioned in. In devastating cases, when there is something wrong with the digital guide or the surgical procedure itself, when you reflect the flaps, you see implants that are positioned out of the bony housing. So that means that in some process, something went wrong. And it's always important for the surgeon to backtrack on to the whole surgical procedure and to determine on which moment that he or she had made a mistake. Okay, so Dr. Lee had performed a little bit more of local anesthesia that would slower or lessen the bleeding in the surgical site. Okay, so like in this case, as I've mentioned before, when using a surgical guide, the surgery can be performed both in a flapless way or in an open way, like this case, using sufficient flap reflection. Also, like this, even if the surgeon decided to do today's surgery in a flapless way, like we're seeing now, you can always switch to fully reflecting the surgical site. By doing this, the surgeon can have more direct access to the surgical site as well as tangibly assess the bone and gum status. Okay, so I think the implant had to be inserted a little bit more deeper, so Dr. Lee is performing that using a hand ratchet. Oh, and as I've mentioned before, since Dr. Lee wants to preserve or make a keratinized onto the buccal side of the implant, a slightly deviated incision line to the palatal side is usually preferred. And since it's much easier to reflect a buccal flap rather than the thick palatal side, in most upper posterior cases, a deviated incision line, such as this case, is usually used. There is is still some amount of bleeding. If the implant positions are unsatisfactory, Dr. Lee might have to make some adjustments manually. Well, maybe there is some mobility on the implant. Or the implant position wasn't in place where he wanted. I think he is taking the implant out using the reverse mode. He has taken implant number 6 on number 16 out and on number 17 as well. So in this case, I think Dr. Lee has decided that the implant positions were too buccally deviated, so there won't be enough bone on the buccal side, or maybe there wasn't enough initial stability in the site. So in this case, then he will probably have to change or switch positions slightly within the preparated bone housing, or to enhance initial stability, he'll have to build up the implant diameter size. I think, he has actually built up the implant diameter size. He is placing an implant with a diameter 5.0 on tooth number 16 area. The length of the implant is 8 millimeters. So in cases like this where there is a lot of bleeding, the surgeon's view can be limited and can lead to insufficient drilling or misplacement of the implant fixtures. In such situations, we can always retrieve the former implant and perform additional drilling or finish implant placement using the conventional method. So freehand surgery training is very, very important. We must never always 100% put our confidence into the guide itself, but always have a backup plan with a freehand surgery method. Either the position or the initial stability of the implant was unsatisfactory for Dr. Lee. So he is, as I've mentioned before, performing additional drilling to the palatal side, so as to make sure that the implant is placed a little more palatally than the former position. So as in these cases, he is making adjustments in a freehand mode. So as I've mentioned before, it's very important to have a good grasp on what you're doing in a freehand mode surgery firsthand, and then get adjusted to using the digital guides. I think the patient has some discomfort with breathing through only his nose. So in these cases, the surgery can take a little longer compared to people who are comfortable with breathing only through their nose. Dr. Lee is now securing the implants into the wanted positions. Oh, the bone graft material used today is osteoxeno, that is a xenograft material. The microstructure of the bone is very, very similar to the human bone and is very highly interconnected with porous structures. The bone has very good osteoconductivity and has minimal amount of inflammation after the graft procedure. So by grafting the osteoxeno into the tooth number 17 area and then compacting it with using an osteotome, as well as performing the sinus floor lift, is a conventional method in a crestal approach of the sinus elevation procedure. I think Dr. Lee is now checking on the temporary abutments and the temporary crown for tooth number 16 and 17 areas. Okay, so by reflecting the flap a little more to the apical portion, the surgeon can check that the implant platform is completely inside the bony housing, or say if it isn't, then he'll have to decide whether some amount of bone graft would be necessary on the buccal side, because usually there may be some amount of dehiscence on the buccal side after implant placement. I think he would be he's now placing the membrane into the buccal flap. Like many moderators of Dentium seminar have mentioned, when performing bone graft surgery, please make sure you position your membranes into the flap first. Always membrane first, because when the membranes become wet, they sort of flap around. They're hard to secure in the position, so it's always important to place your membranes first and then add bone graft material under the membrane. Otherwise, if you have bone graft material first and try to put the membranes over the graft material and under the flap, that would be a hard thing to do. The membrane we're using now today is collagen membrane 2. That is a little different from the collagen membrane 1 that was used in the former cases. This membrane is, as in what I've experienced, a little more less stiff compared to membrane 1. It's a resorbable barrier membrane for GBR cases, and it's, in my opinion, a little more easy to manipulate. And since it has very good tensile strength, it can be used in cases where there is a lot of tension over the graft material. So if you're trying to use a pin to sort of secure your graft materials, this membrane can be your choice. And in some cases, some surgeons might use this membrane for the sausage technique procedures. The membrane shows long-term stability and is reported to last up to 6 months. I think Dr. Lee wants his implant on number 16 area a little more deeper than this position. Okay, and at the same time, he probably would have checked his initial stability, and now he is checking the temporary abutment. Now he could have checked the temporary abutments and the bridges before putting in the membrane, but it doesn't matter as long as you're comfortable with any procedure. But like I've said, always membrane first before graft material. So what you're seeing now is that Dr. Lee has attached the abutment to the temporary bridges, a 2-unit temporary bridge, and he is using this bridge as a positioning jig. Since if there wasn't a lot of position change of implant number 16 and 17, then the abutments would fit well. If not, then you would have to attach the abutments first, just manually, and then reline the bridge so as it fits with the abutment areas. The abutments in this case are custom made according to the planned shape, but since there was some amount of adjustment in the placement of implants number 16 and 17 areas, then additional adjustments for the abutments and the crowns that would be positioned over the implants is necessary as well. So in an ideal situation where the implants are positioned ideally into the bone housing of the patient and the abutments are connected ideally to the implants, then no necessary adjustments would be made, and the gum margin of the customized abutments would fit with the gum level of the patient. But in cases like this, where we've reflected the flap, made adjustments in the position of the implants, then the gum height of the patient and the gingival margin of the abutment might not match. So it's important for the dentist to check these factors and make adjustments if necessary. These custom abutments are usually made in a non-hex design, so to make sure that the abutment can be placed in any direction the dentist prefers. So if Dr. Lee was using a hex abutment, then the axial shape of the abutment would change significantly in cases where the implant was not placed in the exact position according to the planned scenario, as like what you're seeing today. Okay, Dr. Lee has probably secured the temporary abutments. I think you'll have to rotate the abutment on number 17 a little bit And there is still a lot of bleeding in the patient's mouth. Oh, and in cases like this where patients have a hard time breathing through their nose and are gasping continuously during the surgery, it is always very important to make sure that the patient doesn't swallow anything when using small instruments like a hand driver or a abutment. There are always accidents in the dental clinic where the patient swallows something during implant surgery. It would be lucky if it goes into the GI tract, but if it goes into the airway, then it's an emergency. So please make sure that the patient's throat is closed and nothing falls into the patient's mouth. I think the customized abutments are placed in a preferable position, and since there isn't an enough amount of buccal bone, Dr. Lee is performing additional amount of bone graft using osteum xeno, what we've used for the sinus lift procedure. So you can see that the membrane is still present under the buccal flap, and Dr. Lee is now reflecting the flap and the membrane at the same time using a periosteal elevator and putting graft material on the buccal side of the implant. After this, he will probably secure the flap as done in an apically positioned flap surgery procedure. So we will have a thick amount of keratinized gingiva on the buccal side. When performing bone graft on a buccal side of the implant, please make sure that you push your graft material a little more apically before closing your flaps, because usually in cases, some surgeons forget to do this and they have bone graft only like on the collar side of the implant, but we want more bone in the apical area as well. So please try to push your graft material apically. Okay, Dr. Lee is now performing the suture. The operating team has just informed that they will be taking an x-ray after the surgery, after finishing the suture on the upper right area, of which we are seeing now. So during that brief moment, we'll have a short break. I think the x-ray taking will take about 3 to 4 minutes. You can see that tooth number 14 is shaking because of the periodontitis I have mentioned before on the case summary. So an extraction on that area would be necessary in the future. And he is doing interrupted sutures on the upper right area. A suture going along between the abutments. Even in cases where there is a lot of bleeding, it's always very satisfactory for the dentist or surgeon to see that the bleeding ceases when a clean suture is done. So the surgery and the grafting procedure and the membrane placement, all this is very important, but to make sure that your surgery has good outcome, it is always great to check your sutures and to make sure that your flaps are positioned in an ideal position where you can have primary closure with minimal tension in the area. Or in an open membrane case, in an open healing case, you still want your flaps to be in a position that you want them to be and not be folded into some place. Okay, now the surgical team has just informed us that they're going to take an x-ray on the upper right area, so we'll be back within a few minutes. Please take a short break. Okay, we're back, and Dr. Lee has just started surgery on the upper left side. Dr. Lee has mentioned that he doesn't use a tissue punch drill. Rather, he just uses the conventional drilling, the implant preparation, bone prep drill for the start of the implant. So first, he is performing the initial drill that penetrates through the gums and with a shorter length compared to the final length of the implant. So for instance, he would be using an initial drill with 6 millimeter length first to ensure the path of the implant. As I've mentioned before, when drilling, the force is put onto the posterior side of the guide, so the anterior side of the guide might be lifted. So it's always important to secure your guide with your left hand or by using your assistant's hand. As I've mentioned in the case preview, the bone density wasn't good in this area, so Dr. Lee would have to under-drill the area. That is, prep the implant size with a diameter smaller than the implant that Dr. Lee plans to place. Okay, so he's building up the diameter to 3.0. The planned diameter is 4.5 on tooth number 24 area and 5.0 on the molar areas, but we'll have to see if any adjustments would be made. And when preparing the molar areas, the instrument might be too long for the sufficient positioning, so it's always important to check that your drill isn't stuck into the opposing dentition. That is the lower molars in this case. As you're seeing now, an up and down motion is very important to allow copious amount of irrigation. Without it, you'll have overheating in that area, and that will be a great hindrance to the osseointegration of the patient's bone and the implant surface. We don't want bone necrosis to occur during the drilling procedure, so please make sure that your surgical site is irrigated enough. Apart from underdrilling the diameter, another way to ensure initial stability in the maxilla area is to perform osteocompaction. Osteocompaction can be done using the osteotome, as we know, or using a specially designed burr, which is available today in the market. But usually, dentists mostly use the osteotome, but it depends according to the surgeon's preference. Dr. Lee is now positioning the implant for tooth number 24 area. I believe he has slightly underdrilled the area to maximize initial stability. The implant positioned here is supraline implant, the same implant that was positioned in the right side, and the diameter is 4.5 with length 10. After that, he is trying to position implants on tooth number 26 area, but the fixture got stuck in the guide. So in these cases, it is important. Manually positioning the implant into the prep site, like what you're seeing now, can be a good way to finish your implant surgery. It's because the patient doesn't have enough mouth opening, and the implant fixtures get stuck into the guide. You can place your implants first and finish your drilling by repositioning the guide, like you're seeing now. So please make sure that your implants sort of passively go into your prepped bone area. If it doesn't, it would get stuck in between in the process. So in those cases, you can just take it out and retry. Okay, he's finishing the implant positioning with using a hand ratchet. Dr. Lee has just mentioned that the initial stability on the upper left side is a little unsure. So I believe he will be finishing the surgery on the upper left side by only connecting the healing abutments and not performing immediate loading on this area. Now, before the surgery, the surgeon can analyze the bone density through the CT scan, and keeping that in mind, make adjustments in the drilling sequence to allow for sufficient initial stability during implant placement. But the situations can always differ from what we've planned to do, so making the right decision between each step is very critical for promising outcomes of your implant surgery. I think tooth number 27 area has enough initial stability, but if the other parts don't, then Dr. Lee won't take the adventure to do the immediate loading in these areas. Okay, Dr. Lee has got to take another x-ray on the upper left area, so we will be taking another short break before returning to our surgery. Okay, so we're back. Dr. Lee would have confirmed the implant positions, and yes, as I've mentioned before, because the bone initial stability and the bone quality on the upper left area wasn't as satisfactory as we would have wanted them to be, the upper left area would be finished by connecting only the healing abutments. On another note, initial stability can be checked with various instruments that are available in the market. EasyCheck from Dentium is one of these products and can be used on the abutment level. A recommended number from this device is reported to be over 65 for immediate loading cases. Maybe Dr. Lee will check on the temporary crown on tooth number 16 and 17 area before finishing today's surgery. Usually the pre-made bridges have an internal gap up to 1 millimeter in multiple cases. But in cases like this where we are only splinting like 2 to 4 crowns, usually a minimal amount of gap of 0.5 millimeters is put into the crown, so no additional relining is necessary chair side. Okay, so Dr. Lee is now checking the temporary crowns. If the occlusion is okay, I believe he will wrap up today's surgery. After the surgery, we will have a short break, and after the break, we'll have a short Q&A session. The break time would be around 10 minutes, so please take your time. And if you have any questions or comments, please do not hesitate to express them in the window below. Okay, the crowns are very well set into the patient's mouth. Dr. Lee is checking on the occlusion and the lateral guidance. Okay, so Dr. Lee has just finished his surgery. We will be having a short break for 10 minutes and return with a Q&A session. Thank you for your patience and time. Okay, thank you for your patience. We are back with the post-operative radiograph. As you can see, there are implants placed in the upper right and upper left areas with a small amount of GBR and sinus floor elevation on tooth number 17 area. The implants are positioned a little deeply into the bony housing, but are nonetheless secured well into the patient's bone. And since Dr. Lee has only performed the provisionals on the upper right side, he will have to check the initial stability or the stability gain on the upper left and proceed with the temporary bridges within a few months. It takes time, usually about 3 months to 6 months maximum, according to the patient's status and medication or medical status. Okay, so now we will move on to the Q&A session. Okay, so we have 2 questions that have come in. Question number 1 was, what are the criteria for selecting an abutment in a full case and the tips for provisional? This is a very wide case that some very famous lecturers could talk about this topic for over an hour, but to just convey my opinion on this question, I think first it is very important to choose the implant places where you have achieved the best initial support. So for instance, if you have placed, say, 8 implants on one arch, but could only achieve stability in 4, say like on maybe 2 molar or premolar areas on each part. Each part of the arch, then the abutments can be secured on only these areas. You don't want abutments on other implants that didn't have enough initial support stability. Also, please make sure that your abutments match the crown height space and vertical dimension of the patient. It's critical that you have the concepts of fabricating complete dentures when you're doing a full mouth case. So please check your patient's jaw position, vertical dimension, everything that has to be processed before making dentures. The lateral guidance of your provisionals can differ according to the patient's status or the implant placement positions, but make sure that the posterior support is firmly established firsthand, very important. After that, if your provisionals have enough posterior support, then you can have the provisionals for some amount of time. And if the other implant areas have increased stability over time, then you can maybe add more abutments above those implants and establish, say, a mutually protected guidance. But in most cases, when you're doing a full mouth case, it's usually done in the elderly patients. So usually a group function occlusion can be made for your full arch provisionals. And after that, please check that your patient is very comfortable with the actual vertical height of your provisionals and the guidance, as well as the jaw position, everything that has to be checked in this complete denture, as I've mentioned before. And if everything's okay, then you can move on to your final prosthesis. Okay, question number 2 was, it seems that the buccal thread was exposed on the GBR site that was applied to the buccal side of the upper right implants. Can buccal bone be made even if immediate loading is applied to the transmucosal GBR? It's a very good question, and as far as I know, this method isn't actually a gold standard, but is nonetheless being widely applied in clinics. I do this to my patients as well. But just to think about it, I think when even in transmucosal GBR cases with immediate loading, the most important factor for GBR outcome is that your flap is immobilized, so your flap doesn't move around. And in cases where only the buccal bone is added and the flap, as long as it's secured firmly to the buccal side of your implants, then the provisional itself or the loading itself won't actually cause much mobilization to the graft material. That is, if you had enough initial stability on your implants. But thinking backward, since you have enough initial stability, then you could place your provisionals in the first place. So we wouldn't have to worry about that. And according to what I've done to my patients, this transmucosal GBR with immediate loading shows moderate to very satisfactory outcomes. But still, it isn't a gold standard. So please make sure what the most important factor is when you're performing GBR, and to make sure that your flap is securely put on to or sutured to the site where you have placed your implants and placed your graft material. Okay, I think those were the 2 questions that had come in. And thank you for joining us for our live surgery today. Our next live surgery would be the 5th of August. And please keep a note if you are willing to join us again on our next session. Thank you very much, and we'll see you on our next session. Bye.